grantee success. So today, we're going to expand upon one of these core competencies, partnerships and collaboration. So today's focus on building and sustaining partnerships is one of 3 areas SPRC plans to present for the new Cohort 9 Garrett Lee Smith grantees and the new National Strategy grantees who are also participating on today's call. This webinar will provide a brief introduction to community provider partnerships, and you'll be actually broke out into breakout rooms, such as Dominique indicated earlier, so that you would actually have an opportunity to network with your peers. So you may actually see a private chat by Ellie Stout. She's our suicide prevention manager to help identify which breakout rooms you would be most appropriate for attending. So if you see a message from her, please just let her know which number you're calling in from so that we can make sure that you're in that room, in the right room. And at the end of the presentation, we're actually going to be sharing some really helpful resources for those interested in learning more about capitalizing on their partnerships. Growing recognition of the importance of understanding partnerships between clinical and community-based programs and services is critical to promoting suicide prevention as a core component of healthcare services. So, however, it actually appears that the term partnership is used by many in the field to describe virtually all interactions with another entity with which they are involved, regardless of the strength or pattern of the relationship. So the purpose of today's webinar is to actually introduce you to strategies for reaching out to prospective partners, key components of establishing MOUs or other formal agreements for suicide prevention, key considerations in reaching perplexing partners or settings, and that's actually when we're going to be breaking out into the breakout room, and criteria to help consider what level and scope of partnerships to evaluate. So we know that from our recent grant proposals, many of you have actually emphasized that you would be developing or already have actually established partnerships to help you achieve your goals. And despite this, we actually wanted to do kind of a brief overview of why partnerships are important, because we can't emphasize enough how important community partnerships can be to your program's success. And we have learned many things about creating and maintaining partnerships during the past decade. So although there are dozens of reasons, we wanted to share just a few that we felt were relevant for today's webinar. So the following list is actually from the National Strategy for Suicide Prevention. And so we just wanted to kind of just share these with you. And the first is to improve an individual's prognosis for recovery. And some risks, such as having a substance abuse disorder, losing a loved one, or career failure, may be recent events that could actually increase the immediate risk for suicidal behavior. And suicide prevention actually requires support systems, services, and resources in places that promote wellness. Partnerships can help ensure that these actual additional services are available. To increase teamwork among providers in addressing needs of those at risk, clinical and community-based programs and services play a key role in promoting wellness, building resiliency, and preventing suicide behaviors among various groups. The timely and effective cooperation, collaboration, and communication between mental health and substance use providers and sources of support in the community are extremely critical to promote patient safety and recovery. Mental health and substance use providers should actually develop linkages with community-based support, such as community agencies for suicide prevention, mental health advocacy organizations, aging services, veteran support organizations, and programs that provide peer support services are especially critical during this period of time. These programs can help foster a sense of connection and belonging and provide critical needed services, including employment and vocational help housing assistance, social interactions that are not focused on illness, and peer support. And sometimes these are the things that we may tend to forget that a person really needs in their lives. The third one is to improve coordination of services. So greater coordination, and this is where most of us are in regards to some of the proposals, is the greater coordination among the different programs that provide services that address mental health, substance use, and physical care will also increase access to care. This coordination can range from information sharing among different service providers to the delivery of these various services in actually the same settings. So these linkages will help provide multiple access points for behavioral health care and many right doors. I know you've been hearing that phrase lately, but so it's the many right doors to treatment, and thereby really helping to ensure that individuals who may be at risk for suicide behaviors are actually connected to the appropriate sources of care. And the fourth is to access or leverage scarce financial resources effectively. And suicide prevention efforts should engage multiple partners and sectors, focus on the entire lifespan, and provide services that are culturally and geographically appropriate. Many of you already know all that, right? However, even though we know that most states have suicide prevention plans in place, there is much variation amongst those plans. So for example, while most plans focus on the entire lifespan, some address only children and/or youth. Most plans do not include private sector involvement. And furthermore, many do not even identify staff positions that are fully dedicated to suicide prevention that can support the work of planning, implementation, and evaluation at the community level. Even recently, healthcare reform efforts can also be used to create financial incentives for incorporating suicide prevention activities into clinical settings, and to encourage the better coordination or integration of physical and behavioral health services. So as an example, the Prevention and Public Health Fund, created by the Affordable Care Act, provides support to states and communities for integrating these particular services. So I wanted to ask Scott from Tennessee.
Well, first of all, I want to applaud SPRC for their efforts in making sure that grants that have been funded under the Garrett Lee Smith are getting technical assistance, such as the important issue today. We've been very fortunate in Tennessee to have been in existence now for 14 years, and we really believe the public-private partnerships are critical to the success of the Tennessee Suicide Prevention Network's projects across the state. It's so important to maintain regular communication to see what people's needs are, what their recommendations are in regards to mental health and suicide prevention. We reach out to each one of them via email, phone calls, in-person meetings, regardless whether they represent state departments, community mental health centers, or even if they just are concerned citizens, especially survivors or family members that have lost someone to suicide, or if there's someone that is in recovery that is an attempter. We're always trying to work with these folks and trying to organize projects with them to look at ideals that they could benefit the network. We also invite them to meetings of our regional groups and our county Pacific task forces so that regular members can provide assistance as well. These meetings are an opportunity to provide the group and individuals with a better understanding of our current projects and our overall functions of the network. And responding to their needs help us secure a buy-in to the network and our objectives, and basically making sure that these connections can be established and can be far-reaching effects for both our statewide efforts and our regional. And so public-private partnership is so critical for you to form within your grants. Thank you.
Thanks, Scott. That's a great way to move into our next set of slides. I really appreciate you coming on and really sharing what you guys have learned. So thank you so much.
Thank you for having me.
Yeah. So let's turn our attention to actually how to uncover the specific partners that are best to really fit your program and how to get your foot in the door. First, think about your goal and create a list of criteria. kind of what you see here, that will help you pinpoint the partner who can best help you meet them. And here are just a few of the things that we typically consider when searching for a new partner. Who are the target audience? What's the size of the kind of the client base? Who are they trying to reach? Willingness to partner, available joint marketing programs, available technical fit. Is your program more involved in technology? And does that particular program, organization, do they actually support that? Do you have mutual clients? And is the existing partnership or potential partnership, is there a conflict of interest? So next, it's time to narrow down a short list of specific programs that you want to approach about partnering. So start by actually kind of jotting down the players in your target setting. But don't forget about the little guy. And what I mean by this is uncover some of those smaller programs, those littler agencies, maybe some of those recovery programs that we talked about before, maybe some of those private organizations. And just take a deeper dive into kind of uncover what those particular programs have that may be different. They may have different types of funding. They may be other types of violence prevention programs that may actually be perfect for your program and really fit into what your goals and objectives are trying to accomplish. And once you have this inventory, do your homework and evaluate each potential partner against the criteria you actually identified in the last step. And based on that assessment, prioritize the top 3 programs you actually want to target. And so now you know who you want to talk to, right? So the next challenge is what do you actually want to say to them? Before reaching out to a potential partner, you actually need to have a clear and compelling answer to the age-old question, what's in it for me? And one of the things to remember that it's about mutually beneficial partnership. So the me in that statement is actually the partner. So here are actually a few things to consider. You want to really think about your target partner's program objectives. And so are they focused on acquiring new clients? Are they wanting to beef up their products? Are they wanting to expand into new populations or settings? And how can you help them make progress towards reaching their goals? And maybe do you share mutual clients? Substance abuse programs and suicide prevention programs actually have mutual clients. So really finding out exactly what, who the clients are that you're sharing. And what else do you bring to the table? Consider things like exposure to your client base or maybe a joint communication campaign. There's a lot of grants in a variety of states, but there may be several grants kind of doing the same thing, all trying to kind of get the same information out there. So really talking about what can you bring to the table, what kinds of things do you provide. All right, so your next objective then is to find the right person to actually talk to at each program or agency or organization. It could even be a state agency. So, you need to find that right person, and you need to schedule a call. So leverage resources like LinkedIn, Facebook, the company's website, and even your own professional network to reach the right contact. Because many of you know, if you don't have that right contact, that your pitch may go out the window. So we want to make sure that we have that right contact, we have the right person that's actually kind of a decision maker and can move it forward. So when you can, ask for an introduction from a mutual contact versus kind of going it alone. This can actually help create credibility and make the first initial conversation go much smoother. In your first email, or even your first voicemail, briefly introduce yourself and your company or your agency or your program, and tell them what you want to do, and touch on the highlights of what's in it for them. If at first you don't succeed, be persistent. They may just be busy and they just haven't seen that email, or they weren't able to respond to your voicemail. So just be persistent. And once you have that meeting on the calendar, be respectful of their time and be prepared. And here's a sample agenda for actually some initial call. So, do introductions, kind of confirm their business goals to make sure that you're both on the same page. Communicate the what's in it for me, and that's actually one of the first rules of adult learning is telling participants what's in it for them. If you want people to buy into your idea, you have to tell them the reasons on their terms. Okay? A discovery call should actually be collaborative. It shouldn't be salesy. It shouldn't be like a sales pitch or anything like that. But it should be open to exploring what each program or agency has to offer. So know ahead of time what you want to get out of the partnership so you can stay focused on your goals, but be prepared to be flexible. And so you never know what actually might come out of that meeting. It might be something that you didn't even anticipate. So I'm going to stop here at the moment, and I'm going to ask you to share any of your comments or any of your questions, and you can type them into the chat box at the left of your screen. And I did see a question by Kim, so thanks, Lisa, for answering that. So if you do have any questions, hi, Cindy. I got your message, so thanks.
Hi, there's a hand raised from Jennifer Fry. I didn't know if she wanted to type her question into the chat.
Thanks, Lisa.
Sure.
Hi, Jennifer. Did you want to type in your question into the chat? Okay. A lot of this information is very basic. You've probably been exploring all of this the whole time. Again, we're just kind of going over and just doing some overview for you. There may be hopefully some little tidbits that you have been able to pick up. But it looks like we are not getting any questions, so I'm going to go ahead and move on. So now that you've met a program or an agency or an organization and you're interested in working, that you're actually very interested in working with, you actually want to negotiate the values and now set expectations with each other. So while many programs don't use contracts with their partners, they may actually set up informal partnerships that will help all parties negotiate value. And so we're going to kind of go through these a little bit and tell you a little bit more about these. Okay, so laying out the mutual benefits of the collaboration can actually help you and your partners decide if an informal partnership is the approach you want to take, or if a more formal partnership is really what is needed. So in an informal partnership, staff members from several agencies actually collaborate as a temporary team to provide multiple services for clients. They provide advising, and they actually consult one another, and it's more of a kind of an exchange of information. There's no contractual mechanism used in informal partnerships, which are readily constructed mostly on a case-to-case basis. So if it's just something that you kind of come together, you're going to address, and you're going to be moving on. Some type of agreement for communication needs to be implemented here as well. So this could be a kind of a checklist. It doesn't have to be a formal plan, but a checklist or some type of just a minimal plan would be great, just so that people know how do we communicate, how do we keep engaged with each other, so that communication actually happens and miscommunication doesn't. The advantages are more services are available for the client, and actually improved service coordination does occur during this particular type of partnership. But some of the challenges with this type of partnership could be breakdowns in service coordination are possible due to miscommunication, and different problem orientations may lead to conflict among members. Okay. So in a formal partnership, agencies or programs or organizations, whatever you may be, they work together on an ongoing basis and are accountable to the written contract, usually with one agency or organization taking the lead to actually ensure the coordination. Case managers, or we actually have a lot of people who call them natural helpers, behavioral health aides, they actually may be supported through this resource because now there's like pooled resources from all members of the team or actually by the particular lead agency. And then some type of more formal communication mechanism in order to actually ensure that, again, no misunderstanding or miscommunication is happening. So again, this is a more formal plan, not just a checklist. And among the advantages of having kind of a formal approach, there are more opportunities for coordinating care. There's actually less duplication of services, and there is a strengthened service integration. And some of the disadvantages are that multiple agencies or organization participation actually may raise costs and take more time to organize and respond to problems. So Cindy, I noticed that you are actually on the call. And I was wanting to know if you would be able to share just a bit of wisdom from your guys' experience related to formal or informal partnerships.
What can you hear me?
I can, thank you.
Okay. What we try to do is do formal partnerships. When we're looking at doing a program, you know, we serve isolated villages, so you want to know everybody who is doing anything similar to what you're doing, or in a setting like the schools, the tribal councils, our behavioral health department, tribal court systems, all those kinds of partnerships or people who are working with the same group that you're working with. And for us, it's kids. So we developed MOAs with the schools, with our behavioral health department, with the behavioral health department, you know, programs that we have at the sub-regional level. You know, Alaska, our service area is almost as big as Texas. So we have sub-regions, and I think it kind of is similar to reservations, but I'm not sure where you guys have huge, you know, laid out communities. So we have sub-regions. For example, we have the Yukon-Kayukuk sub-region, and Galena is the big village of 500 people, and then we have 6 smaller villages around there, you know, that are in that area, and culturally they're similar. So we have an MOA with the school district, and those have been shaky. And then what we do is, once we have that MOA with the school district, we can go into each school and talk to the principal. And the principals bend over backwards to work with us. You know, our original with our last GLS was to do American Indian life skills. This is just to give you an example. And we ran it, you know, had an MOA with the superintendent, and they wanted it too, but they wrote a grant, and it got messed up, and so she didn't want to work with us anymore, but the principals worked with us. So it gets you, you know, those kinds of formal partnerships can get your foot in the door on the local level. So I really encourage doing formal partnerships and then working your informal with them. And it's easy because you have the same group that you're working with, and everybody wants to help out, especially when you're working on suicide prevention or anything to do with substance abuse.
Yeah. Thank you, Cindy. It's really great to hear from you. And and just to hear you guys talk about all the passion that goes on up in Alaska. So thank you. So we're going to move on a little bit because I want to make sure that I'm mindful of the time that we do have to get together today. And I want to provide a couple of more little tidbits for you before we get to Lisa's section. So as Cindy was mentioning, engagement with potential partners from the very beginning really helps to ensure that all partners understand what activities and outcomes they are responsible for. Really getting that information, really solidified in the very beginning. It really creates those champions that are really dear to your heart in regards to this type of work. So communication is a big part of a partnership development. Constant communication should occur to ensure that all partners are on the same page and each knows what the other one is working on. And I believe that ongoing dialogue is so important because it helps to reduce the risk of assumptions and it really encourages you to stay focused on your shared vision. So with that being said, there are a couple of questions that you might want to consider asking your potential partners as you begin to develop MOUs or your informal agreements. So how do the clinical and the community sectors communicate? And then how does each sector view sharing data? All right, so once you've determined which partner that you feel is going to move your program forward, you'll actually begin to think about formalizing that partnership, as Cindy kind of mentioned. So here are actually a few things that you may want to consider. Again, you want to make sure that you clarify the roles and responsibilities. People, including your potential partners, cannot read your mind, so you need to make sure that those are really clarified. Partners should consistently set their expectations with each other. Make sure that you have shared understanding of terminology. We've learned that one sector of health may have a particular terminology and another sector may have a completely different terminology even though they're talking about the same client. So you need to make sure that that terminology that you understand what the terminology is. Not addressing that terminology can actually create miscommunication and disagreement. So again, it's really important. Define intended outcomes of the partnership. In my experience, both sides need to gain something from the relationship for it to be worthwhile. So in addition, it's important to think holistically on how the two entities will work together to achieve health outcomes. And so partners from like the provider agency versus community settings might actually have very different organizational cultures and might have differences in how they actually view things, such as data sharing. So making sure that you're able to really define that before your actual partnership begins. Okay, again, we're going to go ahead and open it up a little bit to make sure that your comments and questions are being answered. So if you do have any comments, please just type them into the chat and we'll move forward. You're very right, Cindy. You have to be flexible. She indicated we even gave the school funds to get the youth, the YRBS data done. Sure, I can put that back. So since we already have our goals set and our grants, how can we apply this new knowledge you are sharing? Well, one of the things is can you actually hold on to that question, and we'll bring that up in the breakout room. I think that's a great question to be able to discuss amongst the peers. Okay? So These slides will actually be archived, so you'll be able to get the information if you aren't able to get it. So Lisa?
Thanks, Patrice. So I'm Lisa Kaposha, the Assistant Manager of Provider Initiatives at SPRC, and I'm also the TA provider for the new National Strategy Grantees. And I'm just going to share some experiences I've had with forming partnerships with primary care providers and emergency departments and some other clinical settings, both at SPRC and in the past working at the community level. And this slide just gives a few examples of partnerships that you could maybe characterize as perplexing. People who don't respond to your efforts to partner, people who might respond initially, you might have a phone call and they seem interested, but then nothing happens, or people who you even kind of form a partnership with and you get down a road and make plans, but then something happens, everything stops, you don't hear from them, or there was a change in leadership. So we're going to look at some of those issues. And my main message is that when you're working in clinical settings, behavioral health or primary care emergency department settings, there's usually a much more complex story to the reason why someone's not able to partner than just that they're not interested or they're just not being a good partner. So we're going to focus on approaching partnerships with health and behavioral healthcare organizations and just provide a little bit of information that might explain some resistance you might experience and how to kind of overcome that. And we'll look at EDs, primary care, outpatient mental health, and crisis centers. And like Patrice mentioned, I just want to acknowledge that I know many of you bring your own wisdom and experience working with these groups. So please make sure to share that in our breakouts, but also just moving forward with each other in this grant program. So these are some considerations, 4 areas to consider in approaching partnerships, and I'll walk through these with you for each setting. And we're kind of going on the premise just for this discussion that you're going into a partnership hoping another organization will do something maybe new or different. One example might be that you would hope that they would implement new follow-up protocols. So the consideration mission is looking at what is their focus and how does suicide prevention fit. Financing, how does your partner's work, is it paid for? And will there be support for new activities? Challenges, what are the factors that might interfere with this organization's ability to partner with you? And opportunities, what are the factors that might enhance their ability to partner with you? So for the emergency department, it's important to consider that their unique mission is really different from ours in the suicide prevention field. And you should probably think about that every time you interact with someone from an emergency department. They operate 24/7. They're focused on stabilizing and treating an emergency at hand. And they're really looking at the next 24 hours from when they see a patient, not really any time after that for the most part. So they really view themselves as stabilizing and triaging patients until that patient can be connected with the next stage of care. And people who work in EDs deal with a myriad of patients and emergencies and situations in very unpredictable ways, and particularly in comparison to some of the other settings that you might be partnering with. So that's something to keep in mind. And for the most part, in terms of financing, the suicide prevention activities that you ask EDs to take on might not be billable. Or if they are, this may not be clear to the emergency department folks. So this is something you might need to look in together when you partner. The challenges of working with EDs is that, as I mentioned, it's an unpredictable environment for that. It's fast-paced. Some providers have concerns about real or perceived liability issues, and sometimes there are concerns about where they can refer patients to. And the opportunities are things like the Joint Commission National Patient Safety Goals. You might be able to kind of link what you're asking them to do with that. With Affordable Care Act, there are incentives for EDs to reduce readmissions, and so you might be able to show that providing suicide prevention can reduce readmissions. And then boarding, which is when psychiatric patients are kept in the ED until they can see a specialist or until an inpatient bed opens up. That's something that is a problem for EDs, and they want to limit that problem. So to the degree that you can link your programs to that, to alleviating that problem, then you might have a more willing partner. For primary care, Their mission is around prevention and treatment and ambulatory care and managing chronic disease, so that's a little bit more aligned with suicide prevention. Financing is similar to EDs, except in the case of FQHCs, federally qualified health centers, where they might have some more flexible funding because as a nonprofit they can get program grants to address certain populations or certain programs. Challenges for primary care is that they're often asked by public health to be the setting of intervention. So any kind of public health issue is probably something they've been dealing with, and so it's hard for them to meet all of the expectations. So there's a lot of competing issues. And opportunities is that in primary care, they're doing depression screening more, and so adding suicide screening or risk assessment might be able to be paired with that. Also, there are incentives for primary care providers to try to reduce hospital admissions among their patient populations, and so you can also kind of tie your proposals to that. There are more consultation programs coming online where primary care providers can call a team of mental health specialists to get consultation on a specific patient they're seeing. And then for federally qualified health centers, there's a lot of funding and effort going into primary care and behavioral health integration. And so you can kind of link what you're doing with that as well. So there might be some willingness because of those opportunities. With outpatient mental health, I mean, many of you know that the mission is very aligned with suicide prevention in some ways. There's treatment, and they serve mental health conditions and problems. And they are really the outpatient sort of specialists for suicidal patients. For financing, they mainly bill insurance, and so if you ask them to do something like make follow-up calls, that might take more of their time and it might not be reimbursable. If you ask them to prioritize suicidal patients for scheduling, have them be able to see patients sooner, that might not add to their costs. So it's not to say you shouldn't ask them to do things that will cost money, but just consider how it might get paid for. In terms of the challenges, with outpatient mental health, as you know, it's a sort of a more Monday through Friday 9 to 5 hours. And private practice outpatient mental health are less connected to each other. They operate more independently, whereas community mental health centers might be linked together more through state contracting or regulations. And so that's kind of a difference to consider. And opportunities with outpatient mental health, again, is that their mission aligns with suicide prevention efforts. And also, some community mental health agencies house crisis services. So you might be able to partner with two different kind of service settings, but only have to work with one organization. And then the last setting we were going to look at is crisis centers. You're really familiar with this group, I think. They're 24/7. They provide crisis counseling and mental health referrals, and they specialize in working with suicidal clients. So if you're not already partnering with a crisis center, I think you want to probably think about that moving forward. Financing really depends on the model, but many operate with volunteer counselors and very small donations or grants. So even though suicide prevention is part of their mission, they face financing challenges with just adding on services, and you need to be creative and think about that problem with them if you're asking them to do new services. And then in terms of the opportunities, again, they really get it. You don't have to spend time with crisis centers as a partner, getting them on board with the whole reason of working in suicide prevention. They have trained volunteers and professionals, and I think that because of the nature of the work they do, they're probably the most willing of the 4 settings we looked at to problem solve with you. So we just wanted to take a minute to see if you have any questions or if you can share some of your experiences with partnering and looking at what problems have you encountered forming new partnerships, or what has helped you develop successful partnerships. If you want to type a couple of those comments into the chat, we'll see what experiences folks have had, and we'll also look at this in the breakout room. And I'm just going to review some just sort of approaches to partnering before we move into the breakout session. So one thing to consider is that when possible, and if you have the choice, find the right contact person, someone who might be a champion, and you could ask your colleagues for suggestions. You can Google the organization to see what kind of responsibilities the person has, but it's good to see if you can find a person who will champion your partnership. The second consideration or approach is don't assume that they share your view of the problem. You might actually probably with general medical settings especially assume that they don't share your view of the problem. They might be sympathetic to suicide prevention, but they still probably look at it differently. And so that leads into number 3, which is trying to begin with their perspective. You might ask, how does the problem affect you, or what are your concerns about this problem before you propose what you think should happen. And for 4, learning what's on their plate, whether it has to do with suicide prevention or not, is really important. So one example is the Affordable Care Act implementation. Earlier this year, federally qualified health centers were spending a lot of time adjusting their systems and taking on new patients with the Affordable Care Act. And so things like that are good to know about because it could be an explanation for why an organization is delayed in getting back to you. You want to evaluate when to make the ask. I think that's just more of a relationship thing where, sometimes you can go into a partnership and state very clearly what you're looking for out of it, and sometimes you need to hold off on putting that information out there and kind of doing some listening first. Be open to changing your expectations. I think we heard about that from Cindy earlier, and some of the chat comments that folks submitted. They probably will change. Your plans probably will change, so just kind of be ready for that. Also, you may need to adapt tools and resources. So if you have a tool or a resource that you got from a suicide prevention organization, you might have found it on the SPRC website, and many tools are developed for the mental health setting, and they're not all developed for general medical settings. And so you might need to sit down with the people at a hospital or a primary care office and say, how can we change this to work well in your environment? Number 8 is assess where you have leverage. So, if you're a tribal behavioral health agency or a state behavioral health agency and you have the ability to influence what community mental health agencies do to some degree, then that might be a way of establishing partnerships and getting groups to take on some new activities related to suicide prevention. And then lastly, in this section, I just added to use your motivational interviewing skills because I think, in a lot of cases, the partners that you want to work with may get it. They may understand why it's important to prevent suicide, but they are not able to see past the barriers that exist for them on how to do what you're asking. And so you might need to kind of walk them through the process and, again, do a lot of listening to help them get to that point of being ready to make their change. So before we move on, I just wanted to leave you with a few words of hope because in my experience working with clinical care settings, it's helpful to have these. So one is just to really be persistent. I think that's a key ingredient in this partnership work, especially when you're doing systems change work, and a lot of the Cohort 9 work, I think, includes some of those systems change pieces. So don't be discouraged by a few closed doors. Just go, knock on other doors if you need to, and think about it as a long-term process. This is really about sustainability and changing systems, and so it won't happen overnight. And then, make sure to show your appreciation for folks who are responsive to you. And, I think going back to Courtney's opening, show your appreciation to yourself too for this really hard work. So as a colleague of mine would say often, if it was easy, someone already would have done it. So I find those to be helpful words once in a while when you're not getting where you want to go as quickly as you'd like to. So thanks, everybody. And I turn it over to Patrice to tell us how we'll be moving into the next stage of the webinar.
Great. Thanks, Lisa. And I just wanted to acknowledge you've actually mentioned kind of one of the other kind of issues that do come up in regards to potentially, potential issues that will arise during maybe a non-responsive or just a perplexing partnership, is that you really need to make sure that those particular partners that need IRB processes that you really talk to them beforehand, because it really makes it difficult for them to share data with you if that is not considered beforehand. So thanks, Gib. So right now, at this time, we'd actually like for you to hold on to any additional questions or comments you may have and give us just a few moments as we actually transition everyone into either a state breakout or a state breakout room or a tribal breakout room, where you'll actually be gathered to have an open conversation and dialogue with your peers about what we just heard so far.
So we were going to do report outs, and I think, why don't we, Ellie, since are you on the line right now?
Yeah, I am.
Can you hear me? Why don't you give a quick summary of what we talked about in the stateroom?
I'll do my best. There are lots of great challenges and strategies, and I'm sure it was similar in the tribal room. People are working with all different kinds of partners. So some of the, I think, cross-cutting challenges that we talked about were things like staff turnover, so you have a great relationship and then that person leaves and you have to start from scratch, or that kind of competition between different agencies for resources. So if another agency isn't getting many resources from you, they may not be that interested in partnering. Challenges around data sharing. People talked about other agencies and organizations not wanting to share data for fear of how that might reflect on them. There were some other challenges we talked about, but some great strategies, including folks who had already engaged some of their partners for this grant early on in their planning. Some people talked about leveraging opportunities when you see them. So the lead for another agency has a personal interest in suicide prevention, sort of building on that, or leveraging shared interests your group might have with your intended partner. One state had an interesting approach of asking partners from previous grants for really open and honest feedback on how the partnership went, and that uncovered some really important improvements they could make to their partnership agreements in this new grant. And then folks talked about the VA and the National Violent Death Reporting System and child death reviews as great ways to get data, but also in data sharing agreements and MOUs, building in what someone called no blame, no shame components. We talked at the end about some strategies that had worked well with schools, and it was an interesting mix of sort of top-down superintendents, state legislation, but also having a lot of success going from school to school, working at a grassroots level and building a positive reputation for the program that then sort of helped that state move from there. So hopefully I didn't leave out anything big or important. Lisa, feel free to jump in.
I think that covered everything. It was a great discussion, and we appreciate all of the comments that people made and typed.
Yeah, and this is Patrice, and I do apologize. I was talking and I was on mute, so I do apologize for that. Thank you guys for all of the great comments. And in the tribal breakout, we actually had really similar comments as what was happening in the state. And some of the main things with the tribal grantees really had concerns with is that the scope of work that is being asked may actually not be what the provider agency's first priority may be. And so it is really important to really kind of get in that mode of what is it for me, and making sure that me is what the partner, that's you're focusing in on the partner. Some of the strategies in order to really address that is to have concrete activities and set really specific objectives that then are related back to the bigger goal, and making sure that you really leverage your resources. So find out what type of resources you have that could actually be a potential benefit to the other partner that you're trying to ask, such as training or funding, maybe smaller components of part of something that they're already doing. Also making sure that you have the right person, making sure that you really are talking to the right person in order to create the partnership that you're wanting. So again, thank you all for the great conversations. And what I was saying while I was on mute is that please, if there is anybody who that you felt that you really wanted to talk to, please reach out to them. These conversations don't have to stop during this, because the webinar ends. Please reach out to each other, talk to each other, share strategies, and really find out kind of what's working for you and what's working for others. So I have a couple of minutes, and I want to make sure that we do hit on why evaluation is important and why you need to evaluate partnerships. So after, again, that most engaging conversation with the tribes and the states, we don't want to keep you much longer.
You have been muted. Your microphone has been turned on.
To make sure that evaluation is emphasized during this webinar. And as all of you know, partnerships are designed to actually provide a collaborative, integrated approach for developing and implementing a plan. And ideally partnership evaluation planning should be part of the planning partnership from like the very beginning. So why do we evaluate partnerships? We do that to monitor progress, to increase awareness by actually leveraging our resources, which was actually mentioned, and building capacity and actually ultimately reaching our objectives. Again, a lot of those things were mentioned in our breakout rooms. When evaluating your partnership's effectiveness, the evaluation should focus on the partnership that will give you the biggest bang for your buck, meaning data. And data that will be useful for your program, specifically how effective the linkage between the provider-level intervention and the community-level intervention was in achieving the desired health outcome. So in evaluating the partnership, the evaluation outcomes might actually focus on processes, let's say, such as like healthcare system changes. Many of you mentioned referral processes and actually sharing and reporting of data. And then actually some of these will actually lead to improved clinical guidelines, hopefully, and reporting of quality clinical outcomes for those people who are at risk of suicide. And additional outcomes that might be included is actually a community provider partnership evaluation. Could be actually a cost saving and hopefully create some behavior change. So programs should monitor or evaluate their partnerships on a regular basis to ensure that, that the right members are included and the partnership is functioning effectively. And as many of you know, ICF, your technical assistant liaison, will actually be providing information on a process that you'll be expected to participate in called the RNS, and that's your Referral Network Survey. And this evaluation is actually designed to determine commitment and involvement of the partnership in your network to provide understanding of the early identification and referral of youth at risk in suicide. But in addition to that particular survey, which many of you are probably already aware of and have already participated in, your program should really look towards additional evaluation criteria, including effectiveness and outcomes and even the potential for sustainability. So in addition, it should identify lessons learned, such as I was sharing with you earlier with Scott from Tennessee and Cindy from Chief. And the results of the evaluation should actually always be shared with your partners for continuous program improvement. So because community suicide prevention programs tend to have many partnerships in order to achieve goals and objectives, it's important to decide which partners to focus your evaluation. And before you decide which partner to evaluate, you actually need to understand the stage of development in which your partnership is currently in. And this is very different than the evolution of group dynamics, which is like the forming, storming, norming, and performing. The developmental stages of partnerships typically move through something called formation, which is assessment and partner selection, building, and maintenance. So the formation stage, which is described here, includes identifying gaps and needs for developing or implementing a state or tribal plan, what resources are required to activate and sustain the partnership, and it also includes defining relative partners, leadership, vision, mission, and a core strategy for forming that particular partnership. So here, at this particular stage, and I'm not going to go through these because we're kind of short on time, so I'm not going to go through each of these, but again, please look them over, and if you have questions, let us know. But at this stage, at this formation stage, it's really unlikely that outcomes would be actually realistic to evaluate. Okay, so the building stage actually includes training of partners, establishing communication, decision-making, and reporting processes. It also involves developing infrastructure and capacity to function as a group, and actually fostering commitment to the goals or direction of where your program is going. And the examples here are specific to inputs, activities, and outputs for partnerships already established and functioning. And then at this stage, you'll actually have some intermediate outcomes. So as partnerships mature and move into a kind of a maintenance stage, partnership activities focus more on achieving outcomes and ensuring sustainability, and on focusing attention on processes such as communication and leadership. You may even have to go back to formation activities, which we mentioned earlier, if changes occur in the areas of like program goals, which were mentioned on the chat, maybe program direction, maybe something has happened in regards to turnover, member representation, and or funding. And then I wanted to share with you that evaluation activities can be conducted throughout the life of a partnership and can include relatively simple activities, such as meeting effectiveness surveys, identifying barriers or participation through informal interviews, and identifying some critical members or some like critical partners, and really finding out maybe why there's a lack of participation in meetings or activities is really important, because you really want to know why those particular partners aren't coming to your to the table. So as the program's capacity and partnerships grow, a plan for more in-depth assessment of the partnership accomplishments will actually be more appropriate. And I've provided two scales here, the Coalition Effectiveness Inventory, which is a tool to actually evaluate the strengths of your coalition and its stage of development, and the Wilder Collaboration Factors Inventory, which is a free tool to assess how your collaboration going forward, and it's kind of like a 40-item survey that solicits level of agreement with a series of particular statements. So I'm actually going to skip this. If you do have any questions, or anything like that, please just give us an email and we can answer those questions for you. I do want to remind you that throughout the webinar, we had a lot of different resources that Lisa and I both mentioned, and we want you to know that we put a list of those together. So if you're in the left-hand corner of your screen, there's a box that says File Share. If you click on that file inside that box called Cohort 9 Partnerships, you can actually download all the resources that we mentioned. And in addition, you have probably also seen many emails with information related to the training series. So I wanted to quickly remind you that there are several self-paced exercises to help you practice what you heard today. Those include reviewing considerations for building partnerships, completing the researching prospective partners, and completing an MOU checklist for established partners. So that's like taking a new partner that you're planning to do and just kind of plugging them into these worksheets and being able to kind of give you some additional information. Okay. All right. These are the tribal self-paced exercises. All right. So again, if you do have questions, if you would like to know more information, please feel free to give us a call, and you can contact us here, or you can contact your PS and ask them specifically. Please remember the next webinar is going to take December 4th, and it's on continuity of care. And all of these sessions are archived and can be accessed on demand at sprc.org. So thank you, and I really appreciate everybody's participation, and we look forward to seeing you at our next webinar. Have a wonderful